So thank you all for being here bright and early. And I really feel that it's important in anybody that has, any individual, regardless of how they're identifying, that if they have a sexual dysfunction, that you are integrating your care with a physical therapist. And as you'll see as we go through the presentation, there is a lot of physical, there are a lot of physical attributes and dysfunctions that need to be addressed in this population. So he already said about me. And I will say my La Cañada office actually just moved to Glendale, if you're from LA and you know all the little cities. So we just moved a couple months ago down the road. And I have 3 wonderful staff members because there's no way I could have 3 offices without staff to help me. They're all licensed physical or occupational therapists, and they all also hold additional certifications as well, either certified Pilates instructor, registered yoga therapist. 2 of them are registered yoga therapists as well as being pelvic health PT or OT. And then Laureen is a certified lymphedema therapist, which is really nice in like the post-cancer population when they have like swelling and people with like post-operative swelling too that seems to kind of stick around. Those are my 3 offices. Doug already mentioned those. And then most of my practice is pelvic health. So we see men, women, transgender, gender nonconforming, and children with pelvic floor disorders. And there is overlap of pelvic floor disorders with orthopedic disorders. So I would say the majority of our pelvic health patients also have like hip issues or low back issues. So my philosophy is that a good pelvic health PT also has a good orthopedic background, because you can't just treat pelvic health disorders in the small box of only looking at the pelvic floor. And you'll understand that better as I go through the lecture too, how other areas away from the pelvis can affect pelvic floor muscle function. So the objectives for today, we're going to be describing how you all, with my profession, can collaborate to maximize the benefits of treatment for transgender and gender nonconforming clients. We'll discuss a multidisciplinary technique that can help optimize the biopsychosocial well-being of this population, and explain how mental health professionals can discuss the recommendation to their clients to incorporate physical therapy and why that's important to their overall well-being. So why should we integrate care? Why should sex therapists work with physical therapists, specialized physical therapists? This population is very underserved. They have set a very low bar to just be able to access basic health care. So when they're looking for providers, they're looking for the bare minimum, because they've had so many negative interactions with providers throughout their years that if they can just get basic healthcare need met, they're pretty happy, which is really sad. You think of like most of us, if we don't like a doctor, we go try and find another doctor. But if they find a doctor and they just did the basics, they're going to stay with that doctor. And really, they deserve better. We all deserve sort of top-notch, top-quality care. So we need to help them raise the bar, and we can do that by giving them support from multiple disciplines that are affirming their gender. Suicide rate is very high in this population. So up to 51% of transgender adolescents have attempted suicide. And that number is in the female to male category. So they are sort of the most distressed of sort of under the transgender umbrella, followed closely by those that identify as neither male nor female, at almost 42%, and then nearly 30% male to female adolescents. So really high suicide rate. They clearly need a network of support. And we know that adolescents that have socially transitioned have normative rates of depression and self-worth, and only slightly higher anxiety when they're compared to age-matched and gender-matched peers and siblings. And by socially transitioned, I mean that they're presenting as the opposite gender in all ways to the community. So using pronouns of their gender that they're identifying as, dressing as the opposite gender, and so on and so forth. So with us integrating our care together, we can really help love themselves through this adolescent transition into adulthood, and provide them the support that they need. But how can we do better? Because I always feel like doing the minimum, like I said, is not acceptable. We really need to raise the bar. So the first thing we need to understand is what makes up a gender identity. And I love this graphic that was donated to me by Alex Papali, who's a colleague of mine in Boston. And really, I love it because she has sort of what's sensed in the brain, what's sensed in the heart, what you're assigned at birth, and then what makes up your overall being. And so hopefully by the end, you'll sort of be able to understand some of the terminology a little bit better, which is going to help you connect with your clients better. So a gender identity would be their internal sense of being, whether they think they're male, female, neither, both, sort of, gender fluid. It's how they are identifying from like a sort of cognitive sense, what they feel they are. Their sexual orientation is who they are sort of physically and or emotionally connected with. Their sex just refers to the presence of specific anatomy, what they were assigned at birth. And their gender expression is their overall sense of how they express themselves, how they dress, how they act. And it could be masculine or feminine, it could be neither, it could be both. And to point out too that their gender expression does not have to match their gender identity. So they may say, I am a female, but I like to dress in, button-ups and bow ties, which might be more considered a masculine dress. So those don't need to match, and that's okay. We also need to respect the language that they are using. So in my practice, because we are doing muscle work and working with their anatomy, we might say something like the medical name for this structure is the vagina. What do you prefer to call it? And then they've given me a response. For example, actually the word vagina is really distressing to me. I just call it the front hole. So asking what their language is and mirroring it. They might say chest instead of breast. They might say external genitalia instead of penis. So if that's what they're using, take note. Make sure that you are mirroring their language. In all ways, including respecting their pronouns and using them appropriately. Also, everybody that is working with this population should be familiar with the WPATH standards of care, the World Professional Association for Transgender Health. And their website, wpath.org, you can get the PDF document for free from their website, and it's available in 18 languages, written from a very Western slant. That's where the research has been primarily done. So if you have clients that might be from other parts of the world, you would just have to sort of adapt to their culture. And it's general guidelines. They're not meant to be rigid. They are designed to be flexible, and it's evolving. I think they have at least 8 prints. I forget, but it's an evolving document, but it is available for free on their website. And then from your clinic perspective, if you're seeing this population, how can you make them more welcome in your environment? So this is my Glendale office. We have 2 restrooms in suite, and the first thing I did was get rid of the male-female signs, and I just made them both all-gender restrooms. So that's one thing that, okay, like they this practice is aware of sort of what they have to face when they're out in the community. So we try to minimize those barriers as much as we can. You can also wear a pin. So I'm wearing my she/her pin. I'm wearing what my pronouns are. And if somebody is transgender, gender nonconforming, they're going to recognize that right away and immediately feel more comfortable with you. So I got this from the Human Rights Campaign, but I found this one on Etsy. So you can find something simple like that to let your clients know that you're just one step above everybody else. And then you could, make your intake forms more inclusive as well, not just having a box they have to check like male, female, but even like other and with a blank, and let them put their preferred identity on there. Also, what their it is important to get their full history, I feel, because as sex therapists, you do need to know what anatomy they have and how they're using their anatomy when they're being intimate. So having forms on there that aren't so like male-female oriented, wording on there is really helpful. And then also from the mental health perspective, not assuming everybody that comes in that's gender nonconforming has dysphoria. So it's not a 100% correlation with them. And by dysphoria, I mean they have a distress or discomfort around their gender identity not matching their assigned sex at birth. So don't assume that because someone's coming in and they're gender nonconforming, that they're coming in because they have distress about it. They may just be coming in for other reasons, like anyone else. So that's really important to kind of help define and not to label them as dysphoric. And then those anatomy considerations, you may see them write it or term it as like AFAB, which would be assigned female at birth, AMAB, assigned male at birth, or intersex, where they have characteristics of both, or they maybe were not defined enough either way at birth. And then considering how changes in their hormones from the hormonal therapies that they're receiving will change their sexual function. So they'll, if they're adding estrogen, they're going to start to develop erectile dysfunction. So this would be male to female, adding estrogen. They'll have less ejaculate production. They'll have less nocturnal erections. They'll start to experience decreased desire. And they might be confused by that, but you can, confirm and, affirm that it's hormone related. And you can sort of work on that from your perspective. The orgasm quality has been reported to change by different clients to more of a whole body experience, which they have called girlgasms. And one of the more common testosterone blockers, spironolactone, will cause increased urination frequency. Adding testosterone, so this would be someone female to male, their clitoral size will increase. And this is sort of significant too, we'll discuss later when we get to operative procedures, because having increased clitoral size can assist with one of the operative procedures. If they're choosing to have that. So this is a whole discussion we'll have, in a moment. They'll start to experience increase in sexual desire, and you might be helping them sort of work through that. Their orgasms will also change to more genital focus and tend to be more peak intensity and focused, or a boygasm, as I've heard it termed. And then if they still have their vagina and that female anatomy, they'll have tissue changes in their genitalia. They'll have irritation, thinning. If they are having penetrative intercourse still, it may be painful for them, and hormones can be a reason why. And, the main point, we need to work together, because gender affirming care will help have a positive influence on sexual health. So as many providers as we can come together with to support this population and affirm them, it will carry over into other aspects of their quality of life. And so when I want to start off talking about post-operative physical therapy, and I think it's going to be important for you guys to understand what we do. And then I'll come together at the end and tell you why, again, it's important. But you have to understand from my standpoint what sort of dysfunctions we can treat. And I'm going to talk about post-operative first, and then go back and talk about pre-operative, which to me initially seemed out of order. But as I was going through practicing the lecture, I kept referring to surgeries, prepping them for preoperatively, but you had no idea what the surgeries were necessarily. So we're going to talk about the surgeries first, and then we'll go back and talk about prep for the surgeries. So, and also to note that there's not a specific protocol. Like so many things in physical therapy are protocol-based. Like you had your knee reconstructed, like an ACL tear, and you had surgery, and at week 2 you do this, and week 4 you do this. This type of care, pelvic health in general, but especially in this population, is an evolving field. So there's not a specific protocol, and everything that I am presenting today is things that we have done clinically. But as far as like everything we do in healthcare, the science and the research, I guess, would be behind a little bit what we're actually doing clinically. Post-operatively too, some patients may just need a single visit, a single assessment, and do really well. Others maybe have some nerve dysfunction or some clitoral hypersensitivity, or possibly like some pre-existing pelvic floor dysfunction. So they may take several months of PT. Patients will typically refer to having like bottom surgery or top surgery. So I will talk about just a few, and I've included video links, but I'm not going to play the video links because each video is about 5 minutes, so I think it's something you guys can review on your own, and I don't want to take the time here to do that because we have a lot of material to get through. But I do encourage you to view these procedures if you're working with this population so you can understand what procedures they've had or that they're planning to have. Because if you're working on them with intimacy and sexual function, you do need to know what procedures they've had and sort of the extent of the surgery that was performed. So a metoidioplasty would be performed in somebody that's female to male transitioning, and it's creation of a neophallus or a new penis, as that literally translates to, through using existing tissues. So this would be using testosterone to create an enlarged penis, and so it would basically create like a microphallus, and is a much more simpler procedure than a complete phalloplasty, which is typically done over like 3 stages over several months in between. And it is trying to create something that would look more like a natal penis. So it's very involved. It involves lengthening of the urethra as well. So it's done in multiple stages. And for the skin of the neophallus, they're taking skin grafts from donor sites on different parts of the body. So typically the forearm, the lats, which are here in the back, or the adductors on the inner thigh. And they'll have scars from that. And a lot of patients will tattoo over their donor sites to kind of mask it, because otherwise it kind of just looks like a purple, you know, because they are, when you take a skin graft, it's skinning, and you're left with just sort of that exposed layer underneath until it scars over. Other potential surgeries that one may choose to undergo when transitioning from female to male would be removal of the uterus, removal of the ovaries. They may choose to have a scrotoplasty, which is creation of a scrotum with implants placed. They may choose to have vaginal removal, monsplasty, just sort of altering the shape of the pubic mons above the pelvic bone. The metoidoplasty, phalloplasty we mentioned, and then the most common surgery I would say that my understanding is tends to be chosen universally would be top surgery, mastectomy, so removal of their chest, and then chest reconstruction and masculinization. So it's not just a mastectomy like a woman might have after breast cancer. They're actually reconstructing the chest wall to make it look more masculine. And how they do that with the nipple and the areola is they make it smaller, and then they are a little bit more laterally oriented. So if you're just sort of like, you know, if you're a woman and you look at yourself and then you're at the beach and you see how men, like, you'll definitely you can tell the difference in how like a man's chest looks versus a woman's chest. So, and there's a lot of different procedures they can do for that, and various amounts of scarring in each. But that is something that they almost universally have, at least would have first, because that's sort of the most distressing part to them. And you know, that they have, you know, very feminine look up top, but internally they feel very masculine. Mm-hmm. So, but they may not choose to have any of the other ones. So, you know, this is why we have to ask. We can't assume they've had the full procedures top to bottom. We need to ask in our intake. We're transitioning now to talking about surgeries for male to female. A vaginoplasty would be creation of a neovagina, and this can typically be done in one procedure. It would also include a labioplasty and a clitoroplasty, so creating labia, creating a clitoris. The clitoris is created using the head of the penis and just sort of like cut down. So really interesting videos. I mean, I think it's really important for you to understand the commitment level that they're making with these surgeries. They're not small procedures. They take several hours to reconstruct. And then there's a long list of other like facial feminization type procedures that they may have, afterwards. Sort of take a look at like your facial structure versus the men in the room. They have different brow structure, different chin structure typically. They'll do lip augmentation, just to give themselves an overall feminine appearance. Down below, they may like do hip augmentation, buttock augmentation, just things to give them more feminine curves. So there's a huge list of procedures that they may choose to undergo. So I've listed all the ones I could think of there. So if I don't know if I missed any, but it's pretty intense, everything they might be undergoing. So now let's talk about perioperative physical therapy, and perioperative means sort of what's happening before, in, and around surgery. So really it's for you to be able to have the discussion with your clients. It is important to focus on the next few slides to understand how physical therapy care in general can help with them from like an orthopedic standpoint, and how some of those dysfunctions will trigger or contribute to pelvic floor dysfunctions. So we'll start with the pelvic floor muscles, which is maybe the most obvious area to start when we're talking about pelvic health. But as a pelvic health physical therapist, we work internally. We're trained to do that. So we can work intravaginally, and we can do that pre-bottom surgery for female to male. So we can do that to address any dysfunction. We can work in the neovagina for post-op male to female, and we can work intrarectally. And we do that only if it's relevant to their care, and only with consent and them understanding why we need to work specifically in those areas. So we'll get our pelvic models that we have, like 3-dimensional pelvic models that show the muscles, and tell them what muscles we're working on before we work on them, so they feel really comfortable with why we're treating them, how that muscle dysfunction contributes to their sexual dysfunction, to their maybe their painful orgasms, their urinary dysfunction, if they have urinary urgency and frequency, for example. So think of pelvic health PTs when you're dealing with your clients as helping bowel, bladder, and sexual dysfunctions or chronic pain in this area. And we can help with nerve entrapments. We can help with scar tissue. So thinking about all those surgeries that they may have had. Scar tissue can create pain and dysfunction. Scar tissue in and of itself can be very hypersensitive and need to be desensitized, or it might be keloid, like really thick, contracted, drawn up, and that can create dysfunction sort of anywhere in and around that area. So we do scar tissue work as well. And if you have a client and they've had surgery, I think it's fair to ask them if they've integrated a physical therapist in their care to address any of their post-surgical concerns. We can also help with connective tissue mobility. So what that is basically how well the tissue moves, like the skin would roll on top of the muscle beneath it. And that can create pain and dysfunction. Also, in the surgeries that are being performed in a phalloplasty, they're taking the skin graft, and so we can help prep the donor site so that it's easier to remove, because there'll be more freedom of movement for the surgeon. And then we're also considering in this area if they're packing or tucking. So packing, if you're not familiar, would be something that somebody that is identifying as male, so like female to male, they would wear something inside that would give them bulk in their pants, so that they could present outward as more male. And some of them are just cosmetic. Some of them you can actually urinate through. So if they're wearing them all the time, there could be bacteria that develops, and there could be like an increase for infection there. Also, if they're, or on the flip side, I should say, male to female, they may be tucking. And tucking, if you don't know, is when they're taking their penis and they're wrapping it behind them, so that the tip of the urethra is actually now close to the anus. So they can get increased infection there just because of that close proximity. And even having one urinary tract infection, and this goes for everybody, can be a precursor to developing pelvic floor dysfunction. So ongoing symptoms such as urinary urgency and frequency. They might be sometimes diagnosed with, if they have a prostate, they might be diagnosed with non-bacterial prostatitis, which is a musculoskeletal condition of overactive pelvic floor muscles that make them essentially have to pee all the time, or even though they don't have a lot of volume. Women are typically more diagnosed with interstitial cystitis or painful bladder syndrome, which is the same thing. They have to urinate frequently, and they're not necessarily having any leakage or incontinence with it, but they just have a lot of distress around urinating, and they don't truly have to go, because they might feel like their bladder is about to explode, and then they sit down on the toilet and they pee for 3 seconds. So that's not a full bladder. Just to kind of put that in perspective of how the pelvic floor muscles can be affected or treated pre and post-operatively. Around the bony structure of the pelvis, the sacrum, and the coccyx or the tailbone, we're looking at general alignment. And that goes throughout the whole body. We're looking at posture and alignment because anywhere in your body, if you're off, it can affect your pelvic floor. We're in the pelvis specifically, we're looking at sacroiliac dysfunction. We're inquiring about surgeries they've had in this area or that they plan to have. And if I feel like I'm repeating myself, it's because these things are important. It's really important for you guys to understand the surgical component in this population. We're looking at strength, we're looking at overactivity or non-relaxation of the muscles in the area, for example, the pelvic floor. We're looking for weakness. So we're doing a musculoskeletal exam like we would do anywhere in the body as a physical therapist, but we're just trained to specifically assess that in the pelvic region as well. We're looking also if there's any nerve entrapment. When we're looking in the low back, beyond posture, we want to know, have they had like a herniated disc, okay? Because that is relevant from an orthopedic standpoint, but could also be limiting their sexual function. Because if you have a herniated disc, it's kind of hard to have sex like you used to. And you know, what modifications can be used, what exercises can be used to help them just feel better from their herniated disc. So when we are talking about sexual function, we're not just talking about, you know, penis and vagina. Like we're talking about the whole body. And, you know, for example, and I don't have a slide up here, which is, well, I'll mention it. You know, if someone has a rotator cuff problem in their shoulder, they're going to modify the way they have intercourse, probably. You know, there's just certain things not going to be able to do. They're not going to be able to bear weight maybe on their arms. So we're looking at them from total body and addressing all their limitations. And then, so there's a lot of bullet points that repeat, so I'm not going to verbally repeat them, but you have them there for your reference because there is a lot of overlap between regions as far as what we're looking at clinically. In the hip and lower extremity, in addition to what was presented on the previous slide, considering specific hip disorders. So there's a structure called the labrum, which is essentially like a suction cup material in the hip joint. And if that's torn, it can be painful, and that can limit function. A lot of times they have, and with impingement, it hurts if their hip is like really flexed. So that can limit maybe some of their favorite sexual positions. And then also identifying specific hip muscles that are overactive. And very important too, if they're trans male, they are still at higher risk for developing osteoporosis because one of the risk factors for osteoporosis is being a woman, okay? And so just because they have transitioned doesn't mean all of those risk factors are gone. And especially there's other risk factors such as like history of smoking. That's not good for bone health. So, you know, we can just be another provider that's not only gender affirming, but can help reinforce some of the other aspects of general health. Asian and Caucasian women also are higher risk. So if you have like an Asian or Caucasian trans man, they have a couple of those risk factors already on board for osteoporosis. So you know, we're looking at it, like I said, from a whole picture. And where they measure osteoporosis clinically through scans is typically in the hip and the lumbar spine. So that's why I included it in this area. The abdominal and thoracic area are also important for us to identify. And just like a real brief anatomy tutorial, the spine is cervical, and then the next region is thoracic, and then lumbar. So just in case you're not familiar with spinal anatomy. So looking at abdominal area and thoracic area, posture is really important. Checking to see if they have any anterior chest wall tightness. So if they've had top surgery and they have you know, had the mastectomy, they've had chest masculinization, scar tissue, how are they presenting posturally? Skipping down to if they were binding, which a lot of them are doing for mental health reasons, so that they can flatten their chest and have one way to appear as more outwardly male. They're going to start to have restrictions in their ribcage mobility. They're going to have some breathing dysfunction, so we'll be addressing their breathing pattern, and that's important in pelvic floor function, which I'll illustrate in a couple slides. Also considering if they're male to female and they've had breast augmentation, so they need to be able to support it. We see cis female patients that have neck and thoracic pain because their breast size is large. So the trans woman will also sort of be at risk for developing neck and upper back restrictions because of that change in their anatomy. And that's going to be a sudden change to them, right? They didn't have like through puberty to gradually adjust to this new size. It's just sort of there. And those structures in the back, our upper back, mid back muscles, need to be strengthened to counterbalance those forces. And we talked about prepping the skin possibly. So the lats are found in this region, and that can be another way PT can be incorporated pre-operatively. So this would be an example of a binder if you haven't seen one before. It's basically a really like compressive undergarment, and it will flatten their chest. So it will help them with appearing outward as male. They are not going to not use their binders if they're having neck or back pain, so we try to work with them to just make them as comfortable as we can, knowing that they're wearing binders. So we can do things like working on the rib and thoracic spine, hypo or decreased mobility issues. We can make recommendations for them, like would they be okay to wear the binder most of the day, but then switch to more of just a compressive sports bra for the remainder of the day, or maybe when they're at home, they're just in a sports bra. When they go out, they're in a full binder, to just minimize those compressive forces that are contributing to their pain. So, and also making sure that they're in the right size garment too, that it's tight enough but not too tight. And binding does have a influence on the ability to maintain continence. So if you have limited mobility in your diaphragm, which is your breathing muscle, you will have limited mobility or an altered sort of contraction ability of your pelvic floor. And so when they're binding, they may also be experiencing stress urinary incontinence, which means that they're leaking with like coughing, laughing, sneezing, exercise, because the pelvic floor muscle isn't able to contract and function at an optimal rate. So I hope I can play this. Hold on, let me see. So let me come over here. What's happening as we're inhaling, this is the diaphragm, the breathing muscle. As we're inhaling, the lungs are expanding and the diaphragm is dropping. Here's the pelvic floor down here. Look what happens. As you inhale, the pelvic floor lengthens in synergy. As you exhale, the pelvic floor lifts. And you have abdominal wall and muscles in the deep low back that are also doing their thing as well during the breath cycle. But just to highlight the pelvic floor function. So if you're binding through this region and you're limiting diaphragm mobility, you're going to modify pelvic floor activity. So we can be a provider to help demonstrate and educate why that's happening. And and if they're still going to be binding, then what can we identify as pelvic health physical therapists to improve their function so they're not having urinary incontinence episodes? So, and this is something where, I don't think the transgender surgeons are sort of identifying those issues, and they're not necessarily being treated for these things that we can help improve function on. So I like sometimes you may be the provider that they open up to because they trust you, that identify these problems. And then you can say, oh, there's pelvic PT for that. So specifically from the pelvic PT perspective, we're looking at the things we can help, which would be any constipation issues, any bladder leakage or incontinence issues, and helping to improve their defecation mechanics. From a bladder health perspective, we're looking at bladder leakage. If they have I define those before, interstitial cystitis or painful bladder syndrome, extreme urgency frequency issues. If they have urinary retention, which would be an issue with somebody for sure that has a tucking history, because when they tuck, it's an involved process that can take a very long time. So if they tuck and they go out, they are not going to the bathroom until they get home, because they're not going to be able to get themselves back together. So they can start to develop pelvic floor dysfunction from just holding all day. They're basically putting their muscles in a holding pattern. And then we can help them improve voiding mechanics. And this would be pre and post-operatively. So if you think post-operatively, if you're when you're born a man, you're used to standing and peeing, at least as far as my understanding goes of men and how they pee. So now somebody that transitions, teaching them how to stand in pee, because you sort of have to think of relaxing your muscles in a different way. Going from male to female, teaching them how to sit to pee and how to relax muscles and focus on that. So we can help them sort of reconnect with those bodily functions as well. And then our overlap here with our professions, sexual health. So we can address painful orgasm. We can help with reduced orgasm intensity and anorgasmia. Sometimes anorgasmia is more hormonally based, but sometimes it's just a complete lack of connection to the area. And when they have surgery, there's a new pathway that they have to develop for orgasm. So helping them reconnect that pathway. We can help with painful intercourse, whether it's penetrative or non-penetrative. How are they defining intercourse? What's painful? Like I'm not assuming anything that anyone's doing. I ask. We can help with clitoral hypersensitivity. We can downtrain a muscle that's overactive that typically will present as some sort of pain disorder, sexual pain disorder, or it may be they're just weak, and so we can uptrain the muscle. We can help facilitate the contraction. So we evaluate them and we see what they need from a PT perspective. Specific to male to female, I talked about the tucking already, and there's a couple different ways they may tuck with just tape or use a specialized undergarment called a gaff to assist them with tucking. And this would be an image of what tucking would look like in somebody that is pre-bottom surgery, or I won't even say pre-bottom surgery. Maybe they're not going to have surgery at all. So I'll just say someone that has not had bottom surgery. They would move the penis back towards the anus to give it a more smooth appearance, and then they would move the testicle sort of laterally up, and it would all be taped down and not visible through clothing. They're finding out how to do this by going on different YouTube sites. So these were a couple sites that had some of the most hits that I came across using just tape or tape with a gaff. So she's holding that specialized undergarment. The freeze frames. In female to male transgender, we also have to consider if they have their female anatomy that they still need female examinations as well. So we talked about the osteoporosis consideration, but if they've not had a vaginectomy and they still have their female organs, they still need to see a gynecologist, and because they're still at risk for cancers in those areas or disease or infection. So just helping connect them with providers that are gender affirming is really important. If you're outwardly presenting as Robert, making sure your provider is not calling you Jenny. Maybe your assigned name at birth. So just making sure they're in a really comfortable, inclusive environment with care providers. But we need to, as their mental health and their physical health providers, make sure that they're getting all the care they need. And if they do still have vaginal tissue, just that reminder that if they are still choosing to have penetrative intercourse, that testosterone effect on the vaginal tissue that I talked about earlier, so that they may have pain because of those hormonal changes. I'm sure you can't read this study. The main point of this study, I put it up because it was a very recent study that was pro-physical therapy involved in pre-operative care. So the conclusion of these authors, because pre-operative pelvic floor PT had identified that 42% of their patients had pelvic floor dysfunction and 37% had bowel dysfunction. So the author's conclusion was that is very high. And there is a lot of pelvic floor dysfunction. And as we know, and I didn't talk about specifically because it's not a physical therapy, something I'm treating, but it's a consideration, is the potential abuse history that they may have had. And patients that have abuse history are thought to have higher pelvic floor dysfunction issues as well. But the authors concluded that pelvic floor physical therapists do identify and help patients resolve pelvic floor related problems before and after surgery, and that there is strong support for pelvic floor PT for patients undergoing gender affirming vaginoplasty. So that was in that study in particular. But despite this, not every transgender surgeon is referring to physical therapy. So it's important but I think most of them are seeking some sort of mental health. So I think you're the more likely provider, and you're spending an hour with them each time to help identify some other potential dysfunctions that could help them be more complete. So now specifically to sexual function, which is why we're all here to talk about that. After vaginoplasty, they can return to intercourse depending on the surgeon as early as 8 weeks. So that's good for you to know and prep them for and affirm that as well. Sometimes it could be up to 12 weeks, and so it just depends on the surgeon. Here's a lot of studies about why patients are dissatisfied with their sexual health after neovaginoplasty. Some complain of lack of lubrication because the neovagina does not lubricate like a natal vagina. So they are going to have to use lubrication, typically like a thicker lubrication that might be marketed more for anal intercourse. So a thicker lubrication like that would need to be recommended. Or they're having pain. And I've been to many lectures and spoken with a lot of different transgender surgeons across the country. And when I saw the first surgical procedure in one of the lectures, I told them, I said, are these patients in pelvic PT? Because I see what's happening to the muscles. There's a lot of trauma that's happening during the surgeries, because trauma can happen in many ways, and surgery is one way that trauma occurs to the body. And at that point, she had said no. And I said, well, you said the levator ani muscles tend to be in a lot of spasm. Like physical therapists, that's what we treat. We can treat levator ani muscle spasms. So I know since then that practice, and that's at Cleveland Clinic, they now have a physical therapist in-house that treats their patients, for sure post-operatively. I'm not sure about pre-operatively, but I think it makes sense to them the moment you say it. But if they haven't had that correlation made, they're not necessarily referring to PT for dyspareunia, which is just the medical name for painful intercourse in women. Also, 30% are reporting a lack of orgasm. So is it because it's not possible, or is it just because they haven't reestablished that pathway? Or is there some mental health consideration that's limiting that? So, they didn't identify that in that Manrique study, but just to say that 30% were lacking. And then many studies talk about shortening or atresia, which is closing of the neovagina. So that's a big concern. Post-operative is maintaining the depth and the diameter of that neovagina. Also, lots of additional studies that looked at lubrication, orgasm, vaginal depth, and pain together. So it's, those are some more studies that looked at that. There was one study, I thought this was neat, that 97% of their patients did report that they had good or excellent neoclitoral sensation. And then the Maloney study in 2016 talked about other lower urinary tract symptoms that they were having after neovaginoplasty. And then this in turn will impact their sexual function. So that would be sort of just other considerations that we should both be taking into noting. And then just based on time, this is just another study that talks about like sensation after neovaginoplasty. So I'm going to skip this because we're getting a little short on time and I don't have time for questions. This is also a pro-PT study that the authors concluded that pre- and post-operative therapy can significantly reduce pelvic floor dysfunction and produce improve symptoms and quality of life for this population. So I think having like a couple studies you can specifically refer to when you're talking to your clients could be really helpful. Like this isn't just something someone came to us and talked about and said, hey, you should involve pelvic PT and physical therapy in your treatment plan to help your overall well-being. You're saying they're actually starting to research this, and there are studies that show that it improves bowel, bladder, and sexual function. One way that we maintain function is through use of vaginal dilators. And they need to start immediately post-operatively, and they're dilating 3 times a day for the first year. So it is an intense program that they need to commit to before their surgery and make sure they have support ongoing, because if they're not dilating, the vaginal canal will shorten and it will narrow, and then they might not be able to have penetrative intercourse if that happens. Healing does take a long time, and PT can be involved in as early as 2 weeks post-operatively, not necessarily with the internal work, but addressing external restrictions with physician clearance. And this is the most common dilator. I'm pretty sure every transgender surgeon in the country uses the sole source GRS dilators. They have dots on them, so the goal is that they're trying to get to where just 2 dots are showing. So it has essentially a depth indicator that can help them make sure they're making progress and reaching their goals. We can also offer advice on vibrators and specific types of stimulation to help restore sexual function. So this is one that I like that has a deep, thuddy vibration. I also like it too because it's not so anatomy based, it's just smooth, modern looking. So, if somebody does have an issue with something that looks more like a natal penis, it's just got a nice smooth texture to it and a good vibration quality as well. A couple of references for you. I think you should read these. You can recommend your male to female patients these sites, but it's about how these couple different people learn to orgasm after surgery. So it's some popular articles that people refer to. Marcy Bowers is a transgender surgeon up near San Francisco, and she is openly male to female. So she made a transition herself and also is a transgender surgeon as well. And she said in her article that orgasm should be the expectation of each and every patient. So that's what both of us can really work on if that's their primary complaint or one of their complaints, to say that that should be their expectation and help support that. Also, and this would be male, I don't know why it looks so faded, but male to female, using a device such as an O-nut. And this is great for our cis female population too. The O-nut is basically just a penis bumper. It would be worn on their partner, and it would be placed at the base of the penis, and it limits depth of penetration so that they can still go through their motion, but they can't penetrate as deep. So it's great for someone that has a deeper amount of pain. No, for someone that has a deeper amount of pain. So the O-nut is like commercially available, and it just limits depth. There's also other things that are like donuts, but the O-nut is the best device I've seen. It's most comfortable. Some of the donuts on the market are very heavy. I felt one and I thought it weighed like 3 pounds. I don't know. So the O-nut, it's really lightweight, stretchy, comfortable. Those they also stack. So it comes in a set of 4, and you can stack it to the depth you need. So. And we can also help them with other orthopedic concerns, right? If they have back issues or hip issues, helping them figure out if a wedge or a ramp might be a good solution for them to help with their other orthopedic issues. So that can be where we can come into play as well. And we talked about lubricants already too. So these are summaries. We talked about all of this before, but I wanted you guys in your handouts to have a quick reference guide to some of the post-op female to male concerns. If you have a client, you can just kind of like flip to one page real quick and take a look. But don't forget about the fact that they were binding, and they might have some like rib and mid-back issues and urinary incontinence. And then helping assist them with phalloplasty. One thing to note on here is that the best graft that I've heard that has the best sensation is the one that's taken from the forearm. The ones taken from other areas, they have sensation, but they don't really have the ability to necessarily have erotic sensation. Because, for example, because it's interesting, yeah. So also note that the way they're probably going to orgasm is not the way a natal male is going to orgasm. They're not going to necessarily have an orgasm from sliding up and down the shaft, for example. In the surgery, which you'll see when you look at those links that were earlier, the clitoris is actually transposed. So a lot of times the clitoris is still there and just hidden beneath the base of the penis. So their orgasm will likely come from a use of a vibrator at the base of the penis to stimulate their orgasm. So that's an important thing to note. That it's just not automatic for them necessarily to know. They might think they have a penis and it can function like a penis now, and that's not the case. And additionally too, it doesn't have any natural erectile properties in the shaft, so if they want to, as one of the surgical options, they can get penile implants that basically would have like a pump that they can pump to make it rigid so they still engage in penetrative intercourse, but just the act of penetrative intercourse isn't necessarily giving them erotic sensation. So that one mentioned the radial forearm flap there. So it's time to tip the scales because I know you guys are involved on the psychosocial part, and we need to not forget that there's a physical component to their dysfunction and their pain and all the other physical contributions that they have to their bowel, bladder, and urinary symptoms. So I like the tip scale. I wasn't trying to balance it. We need to kind of lean more towards the physical. And a multidisciplinary approach coordinated with all gender-affirming care providers will maximize their biopsychosocial well-being. So as the last point, I just want to talk about our overlap with PT and sex therapies. So what I feel would be like a lot of questions we might both ask and can help you identify their appropriateness for PT. So of course you're asking what issues or concerns around sex would you like to discuss? And what does sexual intimacy look like for you? So I think I said it half a dozen times, having them define how they are intimate and how they are having intercourse. Asking if they have partners, asking about surgical history or planned surgeries so that you can kind of help them understand the best amount of prep they can do both physically and mentally to prepare for those procedures. And then are they having any issues specifically with like pleasure, orgasm, or desire? And sort of affirming those changes that some of them could be hormone based, so that we did talk about that. And then also a sexual trauma history, and then you can observe, you're with them an hour. So urinary habits are the hardest thing to hide, I think. If they have urinary frequency, you might not necessarily know if they went to the bathroom right before they saw you, but if they're having to pee while they're in the office with you, even one time, you can probably assume they went right before and that they have a frequency issue. And, you know, finding a gentle way to bring that up that, you know, hey, like we had a lecture from a physical therapist that actually specializes in pelvic issues. And she had said that we should ask all our clients if they get up to pee, you know, regularly in like multiple sessions. I wouldn't do it just because they come in once, but if you see this like as a pattern, that you might have some, you know, urinary dysfunction, and that is actually something that can help. And, you know, you also report this other sexual dysfunction. There could be a correlation between your pain and the urinary urgency or frequency that you're developing, because a lot of times there is. They both types, like a sexual pain and urinary urgency frequency, could be due to an overactive or non-relaxing pelvic floor. So that would be something that probably needs physical intervention. It's not just sort of like talk therapy that's going to help them. And in general, I think having them take a body inventory is really important for both of our professions. Noting if there's like any distress, or, you know, or areas that feel good, you know, just making sure they're really in tune to their own bodies. Specific to male to female, asking them those questions of lubrication issues, depth issues, penetration issues, orgasm dysfunctions. Specific to female to male, making sure, are they still seeking gynecologic care if they still have any of their female anatomy? That's going to be very important for you to address and identify as well. And last summary slide, all the things we can help with, so flag that. I don't need to repeat those things, but we can help with, you know, that's just a summary of everything we've talked about. Bowel, bladder, sexual dysfunction, general orthopedic considerations from top to bottom. Here's a list of some other resources for you that are specific transgender resources. So those are on your handouts. And references are on your in your syllabi. And then that's the discount code for you all. It's good till end of September, and 30% off on that website for the PDF version of the book only. And if you want a print copy, those are on Amazon that you can get those. Also Soul Source, that website that I mentioned that has the dilators, you can get the book on Soul Source too. So if your client needs dilators, they can get both at the same time from Soul Source. And there are my Instagram handles. I have many for my many different aspects of my business, and email me with any questions. And I think we're right at the time we needed to stop, but are there any questions? Maybe I take a couple before they kick us out.
Wow. That's huge.
Good.
Very interesting.
Well, a question, really. So I'm connected a little bit to a group home that in Phoenix. Now, Phoenix does not have, in my knowledge, most of the resources you're referring to here. So these are kids from the system, CPS kind of stuff.
Right.
They're more or less identifying in some range of trans something, something, something.
Right.
But when I'm around these kids, I'm going, whoops, there's been no filtering, no value, no nothing.
Right.
So I'm wondering, potentially, at least I'm for sure, but these kids have nothing.
Right.
Zero. So if that's possible, I'd love to at least be able to educate a little bit like that.
Yeah, and this is going to be on their YouTube channel. They said in about a week, so
Okay.
You'll have access to
Their
this
YouTube
presentation.
channel, okay.
Their YouTube channel, this whole presentation is
Oh,
being
beautiful.
recorded right now. Yeah,
Beautiful.
yeah. Because I think they do need to just be aware. So when the resources, in Phoenix specifically, I'm not sure
Poor.
of resources like this. And it is unfortunate, even more so that, sometimes this therapy can be very expensive because it's not well reimbursed by insurance. So there can definitely be a cost.
If there are even people there to do this level of
That's right,
work.
yeah, even if.
Yeah, there probably is a pelvic health therapist. So why don't you email me and
Yeah.
I'll look up and see if
Sure.
there's a name I recognize. Their experience with transgender youth or that population, I don't know, but definitely I can find a pelvic health therapist.
Sure.
Yeah.
I don't know if things have changed since I last read this, but I know, because I've met several individuals who identify as trans, and specifically female to male, saying that they legally change their identity to male. Sometimes insurance would give them issues with receiving gynecological services. Is that still like an issue, or?
Could be with some insurance carriers. Excuse me. Could be with some insurance carriers. I don't know about insurance companies. They in general seem like they don't want to cover a lot of stuff. But that would be illegal because it would be required for their health. They should still be covered under a well woman exam if they have female anatomy. But I don't know what individual insurance carriers will do. Yeah. And anybody that is denied that kind of service should immediately complain to the Insurance Board of California or of the Insurance Board of whatever state you're in, and say that they're being denied care. So.
Back to Arizona and tell them to call California.
Yeah.
Just want to point out there's an evaluation in the paperwork on your chair.
Okay.
Yeah.
All right.
Is that for the certification part? Or?
Thank you guys all. And email me if any questions come up after the fact.
Always.
Always. Good.
Thank you very much.
Thank you.
Femina PT?
Femina, yeah. So those are my women's-based services,
Yeah.
pregnancy, postpartum, female sexual health. Fusion Wellness PT is, and it's all under the same building, but it's more to include everybody,
It's just
men,
such a lovely name.
transgender.
It's a lovely sound.
I thought it was
Like
a
a
really
whisper.
nice sound. Yeah, there you go. Yeah. And then the Lady Parts PT is because I do a lot of female sexual dysfunction. The book I wrote is female sexual dysfunction based, so I do a lot of women's health content on that handle. All right.